Is it important for me to stay on my PPI if my doctor prescribed it? Find out on this next episode of Digest This.
Welcome to Digest This, the show that helps you revolutionize your digestive health. Here are your hosts, Dr. Liz Cruz and Tina Nunziato.
Hello and welcome to Digest This. I'm Dr. Liz Cruz and I have Tina Nunziato sitting right here by my side. Thank you so much for joining us on this podcast. And if you are a first-time listener, we welcome you with big wide open arms. We're so excited that you've joined us. We've got a library of podcasts. Please check them out if you get a chance. Over 350 of them out there. If you're a regular listener, we love you so much, and we love that you consistently take the time to hang out with us for 15 minutes or so once a week, okay?
Yep, absolutely.
Yeah, so let's talk about PPIs. I mean, we get that question quite a bit. You know, my doctor prescribed this. Patients that are coming to us that have been referred to us who have been put on a PPI. First of all, what's a PPI? A proton pump inhibitor. And these would be your acid reflux medicines like Prilosec, omeprazole, which is actually the generic of Prilosec. There's pantoprazole, which is also Protonix. There's Nexium, the purple pill. There's, Acifex, rabiprazole. There is,
Is ranitidine considered a PPI?
It is not. It is not. That's a great question. It is actually considered a H2 blocker, H2 inhibitor, which is like a histamine inhibitor. And so let's see. There was one more I was trying. Oh, Dexilant. Dexilant is another one. There's another one. Lansoprazole. Lansoprazole is so there are several different proton pump inhibitors, otherwise known as PPIs, that have been out for a long time. Omeprazole is probably the oldest one that's been out for decades, and really changed the landscape in gastroenterology when it came out a few decades ago, because it really lowered the incidence of people that were coming into the hospital with like a bleeding ulcer. And so really, great medicines when used the right way, when used. So what do we use them for? So we use them in patients with acid reflux. I would say that's probably the number one use of these medicines. People that have erosions, ulcers in their esophagus, in their stomach, even in their small intestine, in the duodenum, we'll use the PPIs on. Mm-hmm. And so, I do get asked a lot.
Talk about inflammation too, just in general
inflammation. Yeah, like inflammation in the esophagus from acid reflux. Mm-hmm. Inflammation in the stomach, that can also be from acid, from bile, mm-hmm. From infection.
So gastritis.
And you can develop, you can get ulcers, you can get erosions, which is more superficial than an ulcer, not quite to the point of an ulcer, but still, I mean, I find those all the time in the esophagus, in the stomach, and even in the duodenum, which is the first part of the small intestine.
And then diagnoses like Barrett's and EOE.
Barrett's, yes. Barrett's, so Barrett's esophagus, which is where you get a change in the lining of the esophagus after years of chronic, of acid just bathing the esophagus, especially in the lower part of the esophagus, which is where we typically find Barrett's. And those cells start to change. And so Barrett's is a diagnosis that we make from, what we see visually when we're in the esophagus with a camera doing an upper endoscopy, and then with the biopsies. So if somebody has Barrett's, I definitely will say you need to be on a PPI. Okay, it's considered standard of care. And the whole thing the end point there is that we're trying to prevent the Barrett's from progressing, because the Barrett's has developed over time from having chronic inflammation there. Mm-hmm. And so what the PPI is going to do is it's going to block the production of acid to hopefully decrease the amount of acid that is refluxing, bouncing into the esophagus, and that's causing the inflammation, which is ultimately then progressing into Barrett's. Right. So putting the person on a PPI
for the rest of their life, usually.
Pretty much. Yeah. I mean, I hate to say that to people, this is for the rest of your life,
This medicine is your death sentence.
But at this point, let's just put it like this. At this point, this is what we have for treatment of Barrett's, as far as the standard of care goes in gastroenterology. Now, if there has been progression of the cells, like when we go in and we monitor the Barrett's, we keep an eye on it, and we do a upper endoscopy every few years. The guidelines say every 3 to 5 years. Go in, take a look, and that's when somebody just has a short segment of Barrett's. People that have a longer segment, being basically meaning that more. The esophagus, the Barrett's is involving more of, it's affected more of the esophagus than just a short segment towards the bottom, okay? So we call it long segment. Long segment means anything over 3 centimeters, okay? So on people with long segment, I typically will repeat an endoscopy much sooner than waiting 3 years, okay? Especially if it's a Caucasian male that's overweight or that smokes, for sure, because those are definite risk factors for progression of the Barrett's into what? Into cancer. Barrett's is considered precancerous, okay? So that's why definitely if someone is diagnosed with Barrett's, I am going to recommend the PPI. If I rebiopsy them, let's say they come back, it's 3 years later, I'm rebiopsying them, and there's been progression of the cells to what we call dysplasia. Low-grade dysplasia or high-grade dysplasia just means that it's continuing to progress, not in a good direction, because it's heading towards cancer, okay? When you look at the spectrum of, Barrett's, low grade, high grade, and then you get into cancer of the esophagus. But anyways, so when they start to develop those type of changes, then at that point, we can start discussing treatment such as ablation therapy, which is basically where you go in and you ablate, you kind of like burn and that tissue, the Barrett's tissue, to try to get rid of it. Okay, that's the whole goal for that. For the most part, as far as I know, because I don't do Barrett's ablation treatment, we don't do that in our practice. We usually will refer patients out for that. And from the latest that I've heard is that insurances are only approving that treatment if there has been progression of the cells in Barrett's. Okay. All right.
So back to the PPIs.
PPIs,
because I want to talk about that, because from a wellness standpoint, with Barrett's, when a person's on a PPI for the rest of their life, we tell them the importance of enzymes at that point, because now they're not making acid. So we've got to try to give ourselves some more support to digest our food, right?
Exactly.
And most patients who are, let's say they have gastritis, right? And or an ulcer or something like that, where we're going to put them on the PPI. The idea is to keep them on the PPI short term, allowing the area to heal, and then the goal would be to try to get them off the PPI. I want you to talk a little bit about the long-term side effects of people being on PPIs, which is why we try to keep them on short-term.
So there is a lot of literature out there that talks about adverse side effects of taking PPIs, on a chronic basis for a long time. There's issues with the bones, okay, because there's concern that the calcium is not going to be absorbed, okay, the way it should be absorbed, because you do need acid, okay? You do need acid to help with that. So
to help with the breakdown of food.
With the absorption, and to help with the absorption of certain minerals, certain certain vitamins, and so calcium is one of those. So if you're not getting the calcium absorption that you need, then that could lead to osteopenia, which is the beginnings of thinning of the bones, and ultimately osteoporosis. There's concern with the PPIs affecting the kidneys, the kidney function. There's been concern about potentially there being some adverse effect in regards to the heart. even as far as neurologic stuff, even with anemia, okay? Because again, you need, if your intestine, if you're not absorbing the iron, then you're going to get anemic. And so being on PPIs can cause anemia.
Yeah. And so one of the things I wanted to bring up is because PPIs, you don't have to be prescribed a PPI.
Right. You can buy it over the counter.
You can go down to the store now. You can self-prescribe, say, I have reflux. I'm going to go buy myself a PPI. And even though on the package it states, this should not be taken long term. Most people are not reading the fine print. And they start taking it and they're like, oh, I feel better. I don't have reflux anymore. And then they're on it for 10 years. Yeah. Right. And that's the scary part. Like if you've self-diagnosed and you've put yourself on a PPI and you've never been seen by a GI doctor, you really do need to get seen by a GI doctor and have that monitored, in my opinion.
Absolutely.
Doctor,
absolutely.
What do you think, doctor?
I agree with you. No, definitely. And that's the disclaimer and that's why they put on, if you go to the store to buy some Prilosec, there's only going to be, from what I understand, just like either a 7-day or a 14-day supply, because they don't want you, they want, that's part of their coverage, covering their butts, saying, don't stay on this forever without seeking medical attention.
Yes. However, you can also buy it in bulk at Costco.
Oh,
and so that's the thing.
Okay.
People are just buying it in bulk, and they're just,
as they do with all sorts of medicines. There's all sorts of medicines. It's very true. But let's talk about. So look, sometimes I'll have a patient who is already on a PPI once a day. Now I scope him and I see that they've got erosions or ulcers. So a lot of inflammation. And they're already on a PPI, okay? So number one, I always tell them, you got to avoid NSAIDs, Motrin, ibuprofen, Advil. I mean, a whole group of category of medicines that people go and buy over the counter and take it like candy, okay? Without knowing that it can really cause also some harm in your body, okay? For example, in the intestine. So those people, I will increase them up to, if they're, let's say, on omeprazole, Prilosec, 40 milligrams a day, I'll bump him up to twice a day, 40 milligrams twice a day. But I do not keep him on that for a long time. Typically, especially if they have ulcers, I'm going to be going back again and re-scoping them in a couple months to make sure things have healed. And then if things are looking good, then I will cut them right back. A lot of people, the question is, well, why do they have an ulcer if they're already on a PPI? Different reasons. And that's a topic in itself. But yes, we do use them. Now, there are some people that we can get off the PPIs, and we certainly try to do that if we can. But look, if they have inflammation, especially inflammation in the esophagus, where we have to be careful that with that chronic inflammation now, they don't progress to Barrett's, or they have ulcers or erosions, we have to use the medicine. We have to treat them.
And there's a benefit to the medicine. I mean,
absolutely.
Like a lot of patients are like, oh, I don't want to be on this medicine at all. They just got diagnosed. I said, look, there's a benefit to the medicine.
Right.
Idea is be on it short term, let that area heal, and then let's get you on some enzymes, right?
Exactly.
So that while you're taking the PPI and then after, so that we don't have to be on it, ongoing. But
let's talk about that for a couple more minutes before we close up here. So Tina mentioned the enzymes already, okay? So look, here's the thing. When you are suppressing, when you're blocking the acid production in your stomach, you are not going to digest food as well. Okay, so you take the medicine and it's supposed to block your acid for about, on average about 12 hours, okay? During that time, you're going to eat. You're going to eat maybe a couple meals, maybe some snacks. You're not going to have your full digesting capability because you're blocking the acid. And acid is important in helping to digest food, okay? Especially protein. It actually helps to kill off viruses that get introduced in your food because your food is not sterile, okay? Viruses and bacteria. So digestive enzymes is something that will help you, that you should be on. If you're going to be on any PPI, you should definitely be on enzymes that you would take with your meals to help you break down your food, okay? Because if not, you're going to have food that's partially digested, sitting there, trying to get digested, making, putrefying, making you bloated, nauseated, not feeling well. So anyways, I just thought I'd end that podcast with that.
Side note.
A little side note. So listen, connect with us. If you haven't connected with us, check go to our website, www.drlizcruz.com. There's a magenta colored button. Click it, schedule a free 30-minute wellness consult. You can do it over the phone from anywhere in the world, okay? And if you haven't rated our program, please rate us and give us a 5 because it'll help other people like you to find us easier. And lastly, if you haven't subscribed to our podcast, please subscribe. That way you never miss an episode. All right, well, we will be signing off now. Thank you so much for joining us, and we will catch you on the next podcast.
Thank you for joining Dr. Liz Cruz and Tina Nunziato. To learn more about their revolutionary products and services, go online to www.drlizcruz.com.